First of all, I want to thank the organizers for inviting us to participate in this session. On the other hand, it's an honor to share it with such prestigious colleagues, Dr. Clarke and my friend, Dr. Francisco Caeiro. Now I will introduce the speaker, Dr. Clarke. She's professor in the divisions of Clinical Immunology and Clinical Epidemiology in the Department of Medicine, McGill University, Montreal, Quebec, Canada. She's co-director, McGill University Health Center Lupus Clinic, one of the largest such clinics in North America. Faculty member of the Center of the Analysis of Cost-Effective Care, Montreal General Hospital. Dr. Clarke is vice chair in the Systemic Lupus International Collaborating Clinics, SLIC, a group of world-renowned lupus investigators. Among her many fields of interest in research is the definition of cancer risk in systemic lupus. Dr. Clarke will speak about malignancies and SLE. Dr. Clarke, please.
So I want to thank the organizing committee for inviting me here today to share with you the unfolding story of lupus and malignancy, which my group has been working on over the last 10 to 15 years. Some of you in the audience may have heard some of this last night when Dr. Murray Urwitz highlighted some of this work when he spoke about the accomplishments of SLIC. I very much appreciate him highlighting this work. I'll present it in a little more detail today. I'll likely finish well before the 6 o'clock or the 5:30 period so that you can ask me some questions. So I've entitled this The Good, the Bad, and the Unknown. And I will bring you through the good parts, the bad parts, and the unknown parts of the research which we've conducted over the last 10 to 15 years. So I must acknowledge my collaborators. I have many collaborators, but perhaps the two most important ones are Sasha Bernatsky in Montreal and Rosalind Ramsey Goldman at Northwestern. And of course, none of this work would have been possible without the multitude of investigators within the Systemic Lupus International Collaborating Clinics. So when one speaks about the autoimmune rheumatic diseases and cancer, one conceptualizes the cancer developing in a patient with established rheumatic disease, and one can also think of the rheumatic disease being secondary to an existing cancer. It, in fact, may be a paraneoplastic syndrome and may antedate the cancer diagnosis by several years. I'm going to try to focus on the malignancy developing in the pre-existing rheumatic diseases, but as you can appreciate, it sometimes can be difficult to differentiate between the two. So I really want to start this talk by telling you the story of a patient of mine, Leslie. This is Leslie in happier days with her husband and her child. And I really want to tell you about Leslie's story because I think it's a story which many of you have probably faced in your own practice. And it brings home to us why this question of malignancy and lupus is so important. So Leslie is a 37-year-old woman who I diagnosed with lupus in July 2009. Her presentation was pretty typical. Pericarditis, she had a membranoproliferative glomerulonephritis, and hemolytic anemia. As I'm sure most of you would have done, I started high-dose steroids, 1 milligram per kilogram per day, and I initiated mycophenolate at 3 grams per day. I tapered the steroids over about a 4 to 5 month period, and I maintained the mycophenolate at 3 grams a day for 6 months. I then dropped her mycophenolate down to maintenance dose, 2 grams a day, and I continued it. I wasn't quite sure how long to continue the maintenance, but I felt certainly, and it is our practice, that continuing 2 grams per day, if the patient can tolerate it, for a membranoproliferative GN for at least 2 years, and ideally longer, would be optimal in this case. So I continued her mycophenolate. She presents in March of 2012 feeling well. In fact, she remarked to me she'd never felt so well. She had a little leukopenia, tiny little bit of thrombocytopenia, but nothing really different from her usual. She was supposed to come back and see me in June. Didn't, because she didn't feel so well. I found that out after the case. In July, she presented feeling terribly fatigued. At that point in time, she had a more pronounced leukopenia, an anemia, and thrombocytopenia. This was repeated. We quickly proceeded to a bone marrow biopsy, and she had AML on a background of myelodysplastic syndrome. So, of course, I wondered, did I do the right thing? Could this have been due to her mycophenolate? Was this just due to her pre-existing lupus? Should I have stopped the mycophenolate earlier? Certainly at that point in time, I stopped the mycophenolate. I continued the Plaquenil. She's since been treated for her AML, in fact, is in remission. I just saw her before I came here and is doing well. I will continue the Plaquenil, and I will not, at this point in time, reinitiate other immunosuppression. So Leslie's case, I think, really hits home the importance of trying to define the risk of malignancy in lupus, and even more importantly than that, trying to define why patients may be predisposed or may be less susceptible to developing malignancy when they have lupus. So I'm going to share with you the results of a recent study by our group in the Journal of Autoimmunity, where we look at the risk of malignancy in patients in lupus. This represents an update of an earlier study that we published in 2005. We had a variety of North American sites. I feel ashamed to say I haven't even shown South America here on the map. We didn't have any sites from South America because South America is not represented within our SLIC group. And then we had a variety of primarily Western European sites and a site in Asia. So what we wanted to do was to compare the observed incidence of malignancy in our lupus cohort with that expected in a matched general population to come up with a standardized incidence ratio. The cancers observed were ascertained by linking the clinical cohort at each site to regional tumor registries to detect cancer. Now, I must comment that these registries do not record in situ cancers very well. Hence, in situ carcinoma of the cervix was excluded from this analysis, and all we were able to look at was invasive carcinoma of the cervix, which will be important, as you'll see a little later on. To determine the number of expected cancers, we basically multiplied the person years in our lupus cohorts by geographically matched age, sex, and calendar year specific cancer rates. So you can see here that we observed 644 cancers in our population of over 16,000 patients, representing 120,000 patient years from 30 centers, contributing data over this interval. We observed this number of cancers. This exceeded the number expected in the general population for a standardized incidence ratio of 1.14 with a very tight confidence interval because we had such a large number of patients. When you look at this SIR broken down according to sex and age of the patients, you see that males also had an elevated SIR. However, this confidence interval includes 1 because of the much smaller number of cancers. When you look at the SIR broken down by age of the patients, you see that it is increased in those patients under 40 and also those between ages 40 and 60. When you look at the SIR according to lupus duration, you see it's highest in the first year of disease and in the years 1 to 4 of disease duration. Now, I've shown you that the overall SIR for all cancers considered is slightly increased at 1.14. This is driven largely by the increased risk for hematological malignancies, primarily non-Hodgkins lymphoma, where the SIR is 4.4. The SIR for Hodgkin's, leukemia, and myeloma is also elevated. The point estimate for the SIR is also elevated. But because these are less frequent cancers, the confidence interval for most of these other hematological malignancies includes 1. But across the board, the SIR is elevated for all hematological malignancies, but most notably for the non-Hodgkin's lymphoma. When you look at this SIR for hematological cancers, broken down according to sex and age, you see it's elevated in both sexes and elevated across all ages. Similarly, when you look at it according to disease duration, you see that the SIR is most elevated in the early years of the disease, but remains elevated through 19 years of disease duration. The point estimate for the SIR is elevated for patients with disease over 20 years, but because there were fewer cancers, this confidence interval also includes 1. So I think the strong message here is that yes, lupus patients have a slightly increased risk of cancer, but they have a definitively increased risk of hematological cancers, primarily non-Hodgkin's lymphoma, really throughout their entire disease duration. Now, there is some good news. When you look at the reproductive cancers, particularly breast, uterine, and possibly ovarian, you see that the SIR for these cancers is less than 1. That is, lupus patients appear to have a lower risk or a lower susceptibility of developing breast, uterine, and possibly ovarian cancers than the general population. You see, the risk for cervical cancer does not exceed 1, but I think this is primarily because in our registries we're only recording invasive cervical carcinomas. We're not picking up the carcinoma in situ of the cervix or the cervical dysplasia. You also see here that the vulvar and vaginal cancers, which, like cervix, are related to HPV infection, these cancers, vulvar and vaginal, are also increased. But certainly the good piece of the news here, this is why I call it the good and the bad, is that this risk for these hormone-sensitive cancers really appears to be decreased, with really, certainly for breast and uterus, confidence intervals which clearly do not include 1. When you look at other cancers, you see an increased SIR with a confidence interval that doesn't include 1 for thyroid and lung, and also a higher SIR for hepatobiliary, but that confidence interval just includes 1. For the other cancers, there really is no signal, although you wonder if we didn't have more prostate cancers, if we wouldn't see a definitively decreased risk of prostate cancer, also another hormone-sensitive cancer. This confidence interval does include 1 in its upper bound, but again, there were very few prostate cancers. So perhaps there's a signal here for decreased risk of prostate cancer. So some of the limitations of this work, one of the first limitations you'll think about is perhaps this higher SIR is because of surveillance, detection, and lead time bias. That is, these patients in our clinical cohorts are subject to increased scrutiny, so perhaps we're detecting subclinical or earlier cancers, and this is why we're seeing this increased SIR. There really isn't very much supporting evidence for that. You will recall that the SIRs for cancers with established screening strategies, that is breast cancer and colorectal cancers, these SIRs are not increased in lupus. We've also shown that breast cancer in lupus patients is not diagnosed at an earlier stage. Also, we've calculated standardized mortality ratios, that is the ratio of patients with lupus dying versus the number of deaths expected in the population. We've done the same thing for the number of observed deaths due to non-Hodgkin's lymphoma versus that expected in the general population, and for lung cancer. And you see here that the standardized mortality ratio for non-Hodgkin's lymphoma is in fact increased. So you might argue that if we were really picking up subclinical or earlier lymphomas, we might have a higher incidence but not a higher rate of death. but this is in fact not the case. So does our study look similar to the results of other large studies? So what I've done here is placed our study in the context of several other large studies that have looked at the rate of malignancy in lupus patients. Now, I must mention that unlike our study, which involved clinical cohorts where we had detailed patient data, which you will see in subsequent slides, which is very important for determining reasons for increased risk of malignancy, many of these other studies were administrative databases or a diagnosis of lupus based on hospital discharge summary. So they didn't have the wealth of information which these slick clinical cohorts provided. All of that basically to say that our cohorts, although assembled differently from the others, had a very similar message for the increased risk of malignancy in lupus. Our cohorts showed 1.14, and the other cohorts really vary between 1.14 up to 1.76. So the message here, I think, is very convincing. Yes, lupus patients do have an increased risk for cancer overall, but it's not substantially increased, and it's certainly not up to the level of a twofold increase. When you look at non-Hodgkins lymphoma, again, our study in the context of the others which have been conducted, you see again a very similar message. Our SIR for non-Hodgkins was 4.39. Other studies have shown SIRs of 3. One has recently shown an SIR of 7. So again, a clear message that there is a substantially increased risk of non-Hodgkin's lymphoma, probably about fourfold beyond that of the general population. Now, for reproductive or hormone-sensitive cancers, the message that we are portraying is very similar to the other studies. Consistently decreased SIR for breast cancer, also for ovarian and uterine. Some of these do not reach statistical significance. That is, the upper bound of the confidence interval includes 1, but this is because they had smaller numbers of patients. But I think the take-home message from our study and from other large studies over the last 10 to 15 years is there certainly seems to be a convincing signal that female hormone-sensitive cancers appear to be decreased in patients with lupus. When you look at cancers which are more related to HPV exposure, again, a similar message in our study and the other studies, a higher risk of vulvar vaginal. Cervix doesn't appear to be increased, but again, I think this is because our study, like others, is not able to pick up the carcinoma in situ and the cervical dysplasia, which has been clearly linked to HPV exposure, and this is greater in lupus patients. And finally, when you look at lung and liver, which we showed were increasing in our population, you again see a similar signal in the other cohorts. So certainly, I think the message here is clear. It's similar in all of these studies. I think there is consensus that it's really this non-Hodgkin's lymphoma and the other hematological malignancies which lupus patients appear to be at increased susceptibility of developing. And on the other side of the coin, there is convincing evidence that the hormone-sensitive female cancers and potentially even prostate cancer are decreased in lupus patients. If you look at the other autoimmune rheumatic diseases, what are you seeing here? In fact, in RA, in females, it's a similar picture. Increased risk of non-Hodgkin's lymphoma and Hodgkin's and lung. Also a decreased risk of breast, ovarian, and uterus. You see a decreased risk of colorectal cancer in rheumatoid arthritis, which hasn't been observed in the lupus patients. In men with RA, similar story. Higher risk of hematological malignancies and lung, and a lower risk of prostate cancer. And finally, for other autoimmune rheumatic diseases, Sjogren's, as you know, a markedly increased risk of lymphoproliferative malignancies. But unlike the lymphomas of our lupus patients, which tend to be diffuse large B-cell, which you'll see in subsequent slides, in Sjogren's, it's more of the malt lymphomas. Scleroderma, as you know, increased risk of lung cancer. Dermatomyositis, a markedly increased risk, as you know, of many tumors, but particularly ovary, lung, pancreas, and other GI tract tumors. And polymyositis hasn't tended to show this increased risk of malignancy that is observed in dermatomyositis. So I think what I want to talk with you now in more detail about is why are we making these observations? Before I do that, I just want to present to you a little bit of work that has been done in looking at malignancy in pediatric lupus. If you will recall, everything I've shown you to date is adult lupus. So we've conducted a smaller study involving several pediatric lupus centers in North America. We involved 10 centers. All of the individuals were less than 18 at entry. In fact, the mean age at entry was 12.6 years. We involved 1,000 patients, contributing 8,000 patient years. So certainly much, much smaller than our adult cohort, but nevertheless enough information to take home a message. So once again here, we observed more cancers than expected for a very high SIR of 4.7. And as in the adult lupus patients, the SIR for the hematological malignancies is most markedly increased. We had 2 non-Hodgkins lymphoma and a leukemia, and then a bladder, brain, breast, thyroid, 3 head and neck, and 4 unspecified cancers. So if you look at these total cancers, if you look at the SIR broken down by sex and age, you see it's elevated in both sexes. You see it's elevated in those under 20 and those over 20. And you see a very interesting pattern here that the SIR is dramatically higher in the first year of disease duration, but it's also high at 10 to 19 years of disease duration. So if you repeat this analysis, excluding those 2 cancers that were observed within the first year of disease duration, you still come up with an elevated SIR of 3. So there appears to be perhaps a bimodal distribution of cancer occurrence in these younger patients, and certainly most of the cancers are developing once these patients have entered early adulthood. So it's critical that once these patients transition from pediatric care, they transition to an adult center which is vigilant about their risk of developing malignancy. So now for the final and for the latter portion of the talk, I really want to talk with you about why have we observed what we have? Why is non-Hodgkin's lymphoma increased? So certainly you've seen the risk is greatest earlier in the disease. Perhaps that suggests that the risk is more associated with disease activity and immune dysregulation rather than long-term exposure to the immunosuppressive drugs. If risk were more related to immunosuppressive drug exposure, you might anticipate seeing a higher SIR in these adults with lupus later on in the disease. So perhaps it's a chronic immune stimulation is leading to upregulated lymphocyte proliferation, which predisposes to a translocation and juxtaposition of an oncogene beside a gene regulating immune function with malignant transformation. Other evidence for immune stimulation, disease activity, increasing this risk of non-Hodgkin's lymphoma is, as I mentioned, we have a predominance of diffuse large B-cell. About 60% of our non-Hodgkins are diffuse large B-cell versus about 30% or so in the general population. We know that these diffuse large B-cell lymphomas are derived from activated lymphocytes, again perhaps supporting a role for chronic immune stimulation, ongoing disease activity, potentiating this risk. A study from Sweden has also shown that in lupus patients with diffuse large B-cell lymphoma, there's high expression of APRIL and BAFF. Perhaps that's mediating the lupus and also mediating the diffuse large B-cell, bringing up the question, perhaps agents, anti-BAFF agents like belimumab, may be useful not only in decreasing lupus disease activity, but also in modifying and perhaps decreasing the role for lymphoma. That's purely speculation. There is no evidence supporting that, but one just wonders that with these findings. So a few years prior, we had tried to disentangle the role of disease activity versus immunosuppressive therapy in mediating this increased risk of lymphoma. So in an initial study which we conducted, we had only 46 cases of hematological malignancies. These were not all lymphomas, which you realize are the ones where the risk is, or the SIR is greatest. Nor did we have information on disease activity in this original study. However, we did show that disease damage, which we used as a proxy for disease activity, seemed to be associated with greater risk of lymphoma development. And we also had a signal that perhaps cyclophosphamide exposure increased the risk for lymphoma. So now we went back to our much expanded cohort where we had 16,000 patients. This time we pulled out our cases of lymphoma, 75 of them, and we also collected detailed data on disease activity and then repeated the analysis looking at the effects of activity versus treatment. This paper has just been published online in Annals of Rheumatic Diseases. So as I said, we wanted to see if disease activity and or immunosuppression increases lymphoma risk. We used a case cohort design. So this was nested within our international study. We involved 21 of the 30 cohorts in the international study. Cases were lupus patients with lymphoma, and controls were lupus patients without lymphoma, randomly sampled from each of the clinical cohorts. So I just want to show you a little bit about how the case cohort design, which we used, is a little different from the conventional case control design, which you may be more familiar with. In a case control design, there is a control, or individual can serve as a control for only a single case, and the control selection is matched for the timing of the case. What we used is a much more statistically flexible and efficient design where the controls were basically randomly selected and their selection is not matched to the timing of the cases. Hence, a patient can serve, this patient here, for example, can serve as a control for many cases as long as that patient is in the cohort and cancer-free at the time that a case is identified. So this allows you much greater statistical power and allows you to develop more precise estimates. So what we did, using this case cohort design, we calculated hazards ratio for lymphoma related to immunosuppressive drug exposure and disease activity. Immunosuppressive drugs were treated both as ever-never, and in cases where we had sufficient information, we also looked at cumulative exposure. Disease activity was expressed as an adjusted mean SLEDAI, with a high score being an adjusted mean SLEDAI of 6 or greater. And the development of this adjusted mean SLEDAI has been published by the Toronto group led by Murray Urwitz a few years prior. And we adjust it for a variety of covariates: geographic location, calendar year, sex, age, ethnicity, presence of Sjogren's based on clinical criteria, usage of steroids, antimalarials, and lupus duration. So in this univariate analysis, if you just look at the characteristics of our 75 lymphoma cases, of which 72 were non-Hodgkins and 3 were Hodgkins, and you compare them to our almost 5,000 cancer-free controls, you don't see a lot of difference. Our lymphoma cases are older at entry, and more are men. 20% are men versus only 10% of the controls. You see no difference in lupus duration at entry or SLEDAI score at entry. There is a suggestion that a higher proportion of the lymphoma cases, 21%, have Sjogren's by clinical criteria versus 19.8% in the controls. When you look at the exposure history to immunosuppressive drugs, you see that the lymphoma cases, 20%, were exposed to cyclophosphamide at some time during their disease course before the development of their malignancy, versus 16.8% of the cancer-free controls. You see, in fact, the cancer-free patients had greater exposure to azathioprine, methotrexate, and mycophenolate than in lymphoma cases. So overall, any exposure to an immunosuppressive drug, in fact, the lymphoma cases had less exposure to an immunosuppressive drug. So there certainly isn't very much of a signal there that immunosuppressive exposure is potentiating this risk of lymphoma. So in our multivariate model, where all of our covariates were entered, the only significant hazards ratio were for males and age. That is, men and older individuals had an increased risk of developing lymphoma. You see that the point estimate for the hazards ratio for ever exposed to cyclophosphamide is 2.8, but the confidence interval actually includes 1. Surprisingly enough, and contrary to what we had hypothesized, there was no signal that high disease activity increased the risk of lymphoma. In fact, the hazards ratio, the point estimate, was even less than 1. We then performed a partially adjusted model. We only include those variables which were significant in the univariate analysis. This is enabled to obtain more precise confidence intervals. And we also forced in disease activity because we were particularly interested in how that influenced the risk of malignancy. Again, you see that men and older individuals are at increased risk of developing malignancy. We do see here that the hazards ratio for cyclophosphamide is almost 2, and the confidence interval just touches 1, perhaps suggesting there may be a weak signal for cyclophosphamide exposure. Interestingly enough, we again saw no signal that high disease activity mediates increased risk. We did see that systemic steroids, a cumulative dose of over 3.5 grams, did have a hazards ratio almost at 2, with a confidence interval that didn't include 1. What does this mean? So is this because this is so highly correlated with disease activity that it's really a proxy more for disease activity than for the steroids itself? It's very difficult, despite doing these multivariate models and trying to disentangle the independent effect of immunosuppressive exposure and disease activity. It's very difficult to disentangle these. But nevertheless, I think we can walk away from this saying that it doesn't appear as if high disease activity is promoting an increased risk of lymphoma, which is contrary to what has been seen in rheumatoid arthritis, with those with very high disease activity are at a much higher risk of developing lymphoma. I think you can also walk away from this and say there really isn't a strong signal that our immunosuppressive drugs are responsible for this increased risk of lymphoma. There was a couple of other case-controlled studies that have looked at non-Hodgkins lymphoma. In this Swedish study, where you had only 16 cases of non-Hodgkins lymphoma, they saw, as we did, that the large majority were diffuse large B-cell. Very few are related to EBV. They also didn't demonstrate that exposure to immunosuppressive drugs such as azathioprine and cyclophosphamide increase the risk of lymphoma, with their relative risks certainly not elevated and confidence intervals including 1. Mind you, they had a very small number of patients. This group has also looked at myeloid leukemia. They have only 8 patients with leukemia, and again, did not see a signal for medications, immunosuppressive drugs, increasing that risk. So what's doing it? If it doesn't appear to be the drugs, it doesn't appear to be the disease activity, what is increasing this risk? Could there be increased traditional risk factors? I don't think so for lymphoma. Certainly for lung cancer, we have seen that the SIR for lung cancer has fallen over the decades, potentially because lupus patients are smoking less. So their increased prevalence of traditional risk factors may have mediated that higher SIR we saw for lung cancer in earlier decades. Could there be a shared susceptibility to lupus and to the non-Hodgkin's lymphomas? No one has really looked at this, and this certainly could be an area for further exploration. Certainly, persistent viral exposure has been postulated, either because of increased infection and or because of decreased clearance. As I mentioned to you, we're seeing that the HPV-associated cancers are increased in our lupus patients. We didn't see an increased risk of invasive cervical cancer, but lupus patients are known to have a higher frequency of HPV infections, and cervical dysplasia and cervical carcinoma in situ are certainly increased. Other work of other individuals have shown that the SIR for dysplasia and carcinoma in situ is elevated up to about 4. We and others have certainly shown that vulvar and vaginal cancers have a very elevated SIR. These are also linked to HPV infection. And a more recent study has shown that cancer of the anus is dramatically increased, and this, of course, is also linked to HPV. The increased risk or increased rate of hepatic cancer that we observed in our clinical cohorts may potentially be due to increased infection with hepatitis B or C. There really isn't any evidence to date supporting that. This is a hypothesis. And certainly in the transplant literature and in the HIV-positive patients, the development of non-Hodgkin's lymphoma has been linked to Epstein-Barr virus. We don't seem to be seeing the EBV virus in our diffuse large B-cell lymphomas, but this is a hypothesis. So now, perhaps even more interestingly, why are the hormone-sensitive cancers decreased? The breast, the ovarian, the uterine, and possibly the prostate. So one can postulate that there's alterations in estrogen metabolism. So patients with lupus have less endogenous estrogen, earlier menopause, and less exposure postmenopausally to exogenous estrogen because of the concern that it may increase lupus activity. However, we see that the risk for breast cancer is decreased both in the pre- and postmenopausal patient. So this alteration in estrogen metabolism doesn't appear to tell the whole story. Perhaps some drug exposures are beneficial. Certainly, individuals are starting to use hydroxychloroquine in the treatment of certain cancers. We haven't seen that Plaquenil confers a protective effect in the development of cancer, but we haven't looked at our breast cancer cases in the same case cohort manner that we've done with the non-Hodgkin's lymphomas, and this needs to be done. Or perhaps genetic factors increase the risk for lupus, but protect, for example, against breast cancer. And we recently published a study where we looked at 10 lupus-related SNPs to determine whether or not they occurred less frequently in breast cancer cases than in the general population, using a GWAS on breast cancer cases from the UK. And really, we didn't find very much. One of the SNPs appears to be occurring a little less frequently in the breast cancer cases, but there's certainly not a strong signal supporting this hypothesis. So in conclusion, basically, we can safely say that the risk of overall cancer is minimally increased, with an SIR of about 1.15 from our study. The risk of hormone-sensitive cancers, certainly breast and uterine, definitely appears to be decreased with SIRs of 0.6 and 0.7, and ovarian also seems to be decreased, and there is a suggestion that prostate cancer in men is also decreased. The bad, the risk of lymphoma, particularly non-Hodgkin's lymphoma, is definitely increased, and the risk of virally associated dysplasias, for example, cervical dysplasia, cervical carcinoma in situ, potentially hepatic cancer, anal cancer, and also vulvar and vaginal are increased. I think Although the risk of cervical dysplasia and cervical carcinoma in situ is elevated in the lupus patients because of aggressive screening programs, this is not progressing into invasive cervical cancer. This is why we're not seeing this increased risk of invasive cervical cancer. And the unknown. Why is the risk of lymphoma increased? As I showed you, it doesn't appear to be clearly linked with increased lupus activity or exposure to immunosuppressive drugs. And why is the risk of hormone-sensitive cancers, as I mentioned, breast, uterine, and potentially prostate, decreased? And certainly this is now our area of further exploration, is why are these breast cancers particularly of interest? Why are they particularly decreased? We have a large number of breast cancers, so we will be able to do a case cohort study on these individuals, looking at a variety of factors that may be potentially mediating this decreased risk. So what are the implications of this for general practice? So I think basically in individuals who have lupus patients who have no history of malignancy, use immunosuppressive drugs as clinically indicated. The duration is determined by the usual risk-benefit ratio. I think if there is a remote history of malignancy, perhaps more than 5 years, certainly more than 10, I would proceed as above. If there is a recent history of malignancy, despite no convincing evidence that immunosuppressive drugs are linked to the development of lymphoma, I would bear in mind the transplant literature, and I would try to avoid immunosuppressives if possible. If rituximab may be appropriate for these patients, if belimumab may be appropriate for these patients, I may consider using that in lieu of cyclophosphamide, azathioprine, or mycophenolate. And I would limit the duration of the immunosuppressive drugs if possible. I must mention we really had little data on mycophenolate because most of our years of observation were before 2005, before its widespread usage throughout North America and Europe. And I think we still have to vigilantly screen these patients. I don't think this decreased risk of breast cancer should give us a sense of reassurance. I think we should continue to screen these women for breast cancer as by current guidelines. And I think that this increased risk for cervical dysplasia and cervical carcinoma in situ calls us or requires us to be even more vigilant in screening for cervical dysplasia than current recommendations suggest. I want to acknowledge the multiple sources of funding and support that I've had for this work, particularly SLIC, CARA, this is a pediatric lupus group. And I just want to list the numerous investigators who have participated in the adult and in the pediatric studies. Thank you.
Dr. Clarke, thank you very much for the very excellent talk. Now we open the discussion. I want to ask the first question. Do you think we have to do or use any special preventive action apart from the cervical cancer screening and to stop smoking in the practical clinic in patients with SLE who were receiving cyclophosphamide, like urine cytology or cytoscopy? Do you think it's useful or it's not proved to?
So I'll tell you what I do in my practice. So in terms of cervical cancer, I do advocate that these women up to age 25 are receiving the HPV vaccine. And in terms of usage of cyclophosphamide, I'm using Mesna every time I use cyclophosphamide, and I am doing urine cytology. And if I see hematuria, which is unexplained by glomerular disease, I am doing an imaging of the urinary tract and a cystoscopy on all of these patients.
Thank you. First question.
Yes, Pat Gaffney from the Oklahoma Medical Research Foundation. So this might be sort of a crazy question, but I wonder, given the propensity for these non-Hodgkin's lymphomas to occur early on after the diagnosis of lupus. Is there any possibility that the lymphoma could actually be driving the onset of the autoimmune disease?
So that's certainly possible. I mean, this was a concern that, the lupus may really be a paraneoplastic syndrome of this lymphoma. So we have excluded these lymphomas that have developed in the first couple of years of disease and still see an elevated SAR for lymphoma around 3. But for sure, these lymphomas that develop, at the same time as the lupus diagnosis or shortly thereafter, it's very difficult to know, could the lupus really be a paraneoplastic syndrome? And yes, for sure, that's a concern.
Al Schofield, also Oklahoma City in the USA. It seems like the one place that diagnostic lead time might come into play is thyroid cancer. So you've had thyroid cancer has tripled in the incidence of thyroid cancer in the United States has tripled in the last 20 years, and that looks to be all diagnostic lead. People get thyroid, chest CTs, MRIs, any kind of ultrasound of their neck, like a carotid study, that finds a thyroid nodule, which gets biopsied with those fine needle aspirations, which only became available roughly 20 years ago. And so it seems like all that additional thyroid cancer is subclinical thyroid cancer that people would have otherwise never found out about. And you wouldn't need much of that in lupus patients, a few extra CTs. And you don't have, and the thyroid cancer wasn't very big numbers. I don't know how you can figure that out, but It seems possible.
No, I mean, for sure, and this is always a concern when you find increased risk of malignancy in these patients who are so carefully followed. Is it all due to this, whatever you want to call it, surveillance, detection, lead time bias? Is it all due to that? Some of it may potentially be due to that, but I feel quite confident in saying that certainly the big signal, the non-Hodgkins lymphoma, which is increased throughout the entire disease duration, and for which there really is no screening, I really don't feel it's due to that. But certainly that blip in thyroid, that may be due to that.
Yeah, and I think just about everybody agrees now the rise in thyroid cancer in the U.S. is all this change in diagnosis. Right. And there's not a real rise in thyroid cancer in the United States.
For sure. And I mean, the lupus patients would be more susceptible to having that than the general population because they're getting their chest CTs and their carotid ultrasounds. No, I hear you, and I agree that may be part of the story for that particular cancer.
Dr. Clarke, in rheumatoid arthritis, the oncogenes BCL6, BCL2 are related with the disease. Is the same in systemic lupus erythematosus, the same oncogenes?
Right. We really don't know. So certainly there are lots of areas for further investigation, and this certainly is one of them. Certainly. And in fact, we're right now looking at the pathology of all of these diffuse large B-cell lymphomas to try to understand a little more about what's going on. But as you can imagine, getting this tissue from all over the world has been an ethical nightmare. But we're in the process of looking at things such as this.
Gloria Vásquez from Colombia. Did you find any serological change in the patients when the lymphoma appear? Like Sjogren's syndrome, the rheumatoid factor and the antibodies negative and in lupus patients. Right. Did you find that?
So I'm not sure we have really done the appropriate analysis to properly address your question. We did find that the patients with lymphoma were a little more likely to have Sjogren's, but in terms of looking at each individual patient in terms of their perhaps serological profiles and so on, we really haven't done that. But certainly this is another area of investigation, particularly with breast cancer, in terms of looking at autoantibody profiles in these women to see if particular autoantibodies may be mediating some protective factors.
Any other question? Can you do a comment about the protective action of anti-malaria that you against the cancer risk?
Right. So certainly in my own cohort, I religiously use antimalarials. As soon as a patient has a whiff of lupus, they're on an antimalarial. Now, of course, you have to remember that I'm from the Cohort, the center where the Plaquenil withdrawal study was conducted in 1991. So if anyone is going to be using the antimalarials, it's me, because I was brought up in that environment. So in terms of what we saw in these cohorts, we really, when we looked in our case cohort study for non-Hodgkins lymphoma, there was no evidence that it was protective. But yes, I mean, we've heard throughout this meeting, particularly from Michelle Petrie, the protective or the beneficial effects of Plaquenil in terms of not only controlling the lupus, but the antithrombotic effects and almost everything else. So one would hope, and particularly also oncologists are starting to use it in cancer, one would hope it would have a protective effect. We haven't seen that. But I would nevertheless advocate its use in all the lupus patients unless there is an absolute contraindication, primarily some pre-existing retinal disease that makes screening difficult, retinal screening difficult.
Dr. Clarke, as you know, there are some differences between SLE patients coming from Caucasian origin and Native American, for example. There are clinical differences, clinical in genes differences. Dr. Marta Alarcón talked recently about it. In the cohort, there are any differences between Caucasian patients, patients coming from other races, other ethnias?
Right. So race has certainly never been a predictive factor in terms of these risks of malignancies. It hasn't been. But, you know, our cohort is primarily North American and Western Europe and a little bit from Asia. Certainly, it would be nice to expand this cohort and bring in other ethnicities and have a sufficient number of ethnicities other than white and black to look at some of these features.
Thank you.
Okay. Is there another question? Well, thanks again to Dr. Clarke, and we finish the session. Thank you.